Endometriosis and adenomyosis are not separate diseases. They are the same pathological program, expressed differently depending on where and how that program is activated. Different location, different architecture, same underlying drivers. Important preface. Please listen to this part. What I'm about to explain is based on established molecular data, genetic and epigenetic findings, and systems-level interpretation of endometriosis and adenomyosis. Some of this is well supported in the literature. Some of it is conceptual synthesis, because the data we have is fragmented and siloed. That doesn't make it speculation. It just means you have to be willing to put in the work to connect the dots that have been studied separately for decades. Let's start with what is already proven. They share the same molecular fingerprint. Both endometriosis and adenomyosis show SF1 overexpression, GATA6 upregulation, GATA2 suppression, local estrogen biosynthesis, progesterone resistance, COX2 and PGE2 inflammatory locking and resistance to apoptosis. These are not surface similarities. These are core transcriptional programs. SF1 is particularly important here. SF1 is not normally expressed in healthy endometrium. Yet in both endometriotic lesions and adenomyotic tissue, SF1 is aberrantly activated by a factor of 12,000 times, allowing cells to make their own estrogen, survive inflammatory stress, resist normal hormonal shutdown. That alone tells us we're not dealing with two unrelated processes. GATA switching is the smoking gun. In healthy tissue, GATA2 supports normal progesterone responsiveness. GATA6 is low or silent. In both diseases, GATA2 is suppressed, GATA6 is upregulated, progesterone signaling collapses, inflammatory and survival genes turn on. This GATA switch is seen in ectopic endometriotic lesions and adenomyotic myometrium. That means the same epigenetic inversion is happening, just in different tissue compartments. Why do they inhabit different locations? Well, for the same principle that endometriosis can be in the lungs or your pelvis. Imagine one shoelace. That shoelace represents a gene that may or may not allow a disease to exist. Throughout the shoelace, the gene, we see the mechanisms for inflammatory, estrogen autonomous, immune evasive, apoptosis resistant. Now imagine that different sections of the shoelace are altered or frayed by genetic polymorphisms, epigenetic changes, mechanical stress, hormonal timing, or immune environment. Depending on where that change occurs, the disease looks different. If the altered section is toward one end of the shoelace, the gene expresses itself as lesions outside the uterus. Maybe it has an affinity for uterosacral ligaments, bowel, bladder, or the pelvic sidewall with enhanced angiogenesis-dependent survival and nerve infiltration. These change mechanisms may end up looking like the common cases seen in endometriosis. If the altered section is toward the other end, that same gene might express with the following. It stays within the uterine wall, infiltrates the myometrium, forms cystic or diffuse glandular invasion, causes severe contractile dysfunction. These change mechanisms may end up looking like something we call adenomyosis. The shoelace didn't change, the expression domain did. That's the key. This also explains why some women are hypersensitive to pain, while others carry stage 4 endo without any symptoms. The shoelace for the first is mutated towards more sensory fibers, and the latter towards less sensory fibers. What determines where it shows up? This is where polymorphisms and local environment matter. Factors that influence expression pattern include the genetic coding you are born with, epigenetic activation or modifications, environmental factors such as chemicals, and exposure to mutagenic material. These changes don't create new diseases. They determine where and how the disease behaves, why they often coexist. This model explains something doctors already observe but rarely explain. Endometriosis and adenomyosis frequently occur together. This was the case for my wife. If they were separate diseases, that overlap would be rare. Instead, adenomyosis typically often appears first, then endometriosis follows. However, at times, they both can progress together, or vice versa, because the underlying program is the same, just activated in multiple domains. Why treatment failures finally make sense. If you treat adenomyosis as just a uterine problem, or endometriosis as just lesions, you miss the shared survival network. That's why hysterectomy may relieve some symptoms but not others. Excision helps temporarily, but disease returns. Hormone suppression works briefly, then fails. Pain migrates instead of disappearing. For persisting states, the treatment was targeting one segment of the shoelace, not the entire program. The most important correction to make. Endometriosis and adenomyosis are not estrogen diseases. Estrogen is a downstream amplifier, not the root cause. The root cause is epigenetic reprogramming, inflammatory locking, immune tolerance, apoptotic resistance. Estrogen production happens because that system is active, not the other way around. So when you zoom out and look at the data honestly, same transcription factors, same inflammatory architecture, same hormone resistance, same survival strategies, different tissue expression. The most accurate model is this. Endometriosis and adenomyosis are the same disease, expressed along a spectrum, not divided by diagnosis. Different location, same program. And once you understand that, a lot of confusion and self-blame finally dissolves.